thank you all very much. It's nice to be with you here bright and early in the morning to discuss this topic, Nocardia and Actinomyces, Nocardia and Actinomycosis. So these two organisms share a lot of similarities, but they also have distinct differences. So I thought it was a great opportunity to discuss both together and to compare and contrast them. So this is a talk that is part of our basic core series. And it's my pleasure to be able to bring it to you all today. So we have a lot of talk objectives that we're going to be speaking about. So we'll go ahead and get started. Now, just to begin, I think it's important to consider some of the taxonomy of gram-positive rods and how Nocardia and Actinomyces fit in the whole constellation of these organisms. So remember that first you have your non-branching gram-positive rods, and those include Propionibacterium and Clostridium among the anaerobes. And then among the aerobes, you have all these organisms listed at the bottom of the slide. So Nocardia and Actinomyces, of course, are branching gram-positive organisms. And the difference between Nocardia and Actinomyces in that respect is that Nocardia are aerobic, whereas Actinomyces are anaerobic. So, an important distinction amongst all these organisms. Now, something we'll repeatedly be saying in this talk is, of course, that if you have a branching gram-positive rod, it's either going to be Nocardia or Actinomyces amongst these two agents, plus the mycetoma agents. But in a gram stain, you really can't distinguish between Nocardia and Actinomyces. It's impossible. So you can't tell between Nocardia and Actinomyces on a gram stain, strictly on a gram stain. You have to go to the acid-fast stains to be able to differentiate between the two. So we're going to start with Nocardia, and then we'll talk about Actinomyces, the second half of the talk, and then we'll compare and contrast the two. So starting with Nocardia, this is not really a very common pathogen. Looking at our number of cases annually here at our institution, we may have a handful of cases per year. But Nocardia is distinct from Actinomyces in that it has the potential for systemic or local suppurative disease, not just in humans, but also in animals. So this is more of a broader pathogen, just doesn't affect humans only. And it is typically associated with the immunocompromised in most cases, but in about a third of cases, it affects immunocompetent individuals. Nocardia has a worldwide distribution. It tends to favor the temperate zones, but it's been described in all continents except Antarctica. So it does occur in more moderate zones as well. And the majority of cases occur in the Americas, Africa, and India. These are more temperate areas for the most part. So when we talk about the Americas, we probably mean the US and some of the more tropical or temperate areas. It's probably less likely in some of the more frigid areas of the Americas. Now, Nocardia is not a commensal. So remember, if you see a Nocardia culture in a human specimen, it's not a commensal. It is abnormal. And it does merit very careful examination. Occasionally you may find Nocardia isolate growing from a patient with chronic lung disease where you do a scan and lung tissue is completely normal. And in those cases, you need to look at that with scrutiny. It may not necessarily represent an acute infection, but nevertheless, it's not normal. Nocardia tends to prefer soil, decaying vegetable matter, very humid and moist environments. A lot of cases involve human exposure to moist environments, either directly through inoculation to the skin, or because it can become airborne in dust particles, it can be easily inhaled. And that's one of the reasons why lung disease tends to be one of the more predominant manifestations in humans. So Nocardia is in the order Actinomycetalis. with all of these different organisms. And when Nocardia was discovered initially, it was thought to be a fungus because of the branching characteristic of its, of its organisms. But upon further examination of the cell wall, it was determined that it shared a lot of similarities to bacteria, and now it's categorized, of course, as a bacteria. As I said before, actinomyces and Nocardia are indistinguishable on gram stain, but Nocardia is distinct from actinomyces in that it is acid fast stain positive, weakly acid fast stain positive, and it tends to have more of a beaded morphology. And so actinomyces, in contrast, is acid fast stain negative, and of course it's an anaerobe, whereas Nocardia is an aerobe. So this is a gram stain of Nocardia on the left, and you can see that it has a kind of a bit of a beaded morphology. And on the right is a modified acid fast stain of Nocardia. So Nocardia, because of its very long long chain fatty acids, tends to retain the carbofuchsin stain during decolorization, and that's the reason why it is modified acid fast stain positive. There are 90 species of Nocardia. Over half of those can cause disease in humans. And when I was a fellow many moons ago, we learned that there were basically two strains of Nocardia to worry about, Nocardia brasiliensis and Nocardia asteroides. But in recent years, because of molecular typing, most of the strains of Nocardia asteroides have been reclassified to things like Nocardia cerasi georgica, for example. And so, did I pronounce that correctly? As a result, you don't really see very much Nocardia asteroides Nocardia asteroides listed anymore as a strain. So I don't know if this is going to end up in a board type situation, whether you'll be confronted with Nocardia asteroides. And many texts still list Nocardia asteroides, but really these are the most common species in the US per the CDC. And of course, there's a lot of geographic variability that can affect the species prevalence. So if you look at the strains of Nocardia in Europe, for example, or in Asia, they may be different than what we see here in the US. So there are two major means of transmission of Nocardia, either by direct inoculation into the skin, this often happens through trauma, or through inhalation through the lungs. As we said, a lot of Nocardia can be transmitted through dust particles, for example, in a humid environment. And after primary infection, you can have widespread dissemination to almost any organ, but predominantly Nocardia tends to favor the CNS, so you should always suspect CNS disease as a possibility, as a secondary phenomenon, particularly in the immunocompromised. You can also have dissemination to the lung if you have skin disease, for example. And there are other sites of dissemination. We'll talk about those in just a minute. And Nocardia is distinct in that it can relapse or progress despite appropriate therapy. So you may give somebody appropriate treatment for Nocardia and they may have a relapse, particularly if they're immunocompromised. So many individuals acquire Nocardia through environmental exposure, as I said before. Things like gardening or farming. If you work in your garden, you get punctured by a splinter, for example, or a thorn. Nocardia can result. I remember, again, in my fellowship some years ago when I was rounding at Moffitt, I vividly remember a case of a gentleman who had AML and was cleaning out his gutter at his home. And as a result of that, he scraped his wrist on the gutter edge, developed a chronic wound there that turned out to be nocardiosis. So that you may see that in a board type setting. You can also see it in Nocardia transmission through healthcare. Contaminated medical devices like IV lines. I don't know if anybody has seen a Nocardia central vascular catheter infection, for example. It can infect defibrillators. It can occur through surgical misadventure, for example. Cosmetic injections, wound contamination. Believe it or not, you can also get nocardia from animal scratches or bites, and there are other specific modes of entry. So about 2/3 of nocardia cases occur in the immunocompromised, and glucocorticoid therapy is especially a risk factor. In fact, there's a 5-fold increased risk in individuals who are on glucocorticoid therapy, and it is dose and duration dependent. So if somebody who gets a Medrol dose pack may be at lower risk than somebody who's on high-dose steroids for an extended period of time. And we can also see it, of course, in malignancies, solid hematopoietic malignancies, patients on chemotherapy, particularly when chemotherapy is paired with glucocorticoid therapy, for example. I believe I read that the risk, for example, with somebody on azathioprine who's also on prednisone is higher than somebody who's on prednisone, for example. Also, those on the calcineurin inhibitors or anti-rejection drugs are at higher risk for nocardia. Among organ transplantation, the first year is the highest risk, and particularly when those individuals are on steroids as part of their anti-rejection regimen. The lung and heart have the highest risk, and from there, the lowest risk are liver and kidney. So think about lung transplant patients in particular being at highest risk for nocardiosis. We don't see as much in HIV because of the advent of very effective antiretroviral therapy. Also, many HIV patients are on Bactrim, right? And Bactrim is highly effective against nocardia. Primary immunodeficiencies, chronic granulomatous disease, for example, also at risk for nocardia. And about 1/3 of cases are in immunocompetent individuals. So you don't necessarily want to think of nocardia as just affecting the immunocompromised, although it tends to do that in the majority of cases. So among immunocompetent individuals, people that we consider immunocompetent, think about diabetics, patients who abuse alcohol or inject IV drugs, for example. Immunocompetent individuals who may be started on TNF-alpha inhibitors, for example. Patients with chronic lung disease, in particular, are at a special risk. And you can, and having concomitant mycobacterial disease, either non-tuberculous mycobacteria or TB, can be a risk factor for also acquiring nocardia. So talking about the clinical manifestations of nocardiosis, many individuals experience more of an insidious onset, although you can really see acute onset as well. But typically, this is an insidious disease that occurs. And the primary infection occurs at the portal of entry. So if you have a traumatic inoculation of the skin, you'll get a primary infection there. If it's inhaled, you'll get a lung infection. And then from there, the infection can disseminate in about 20 to 50% of cases. So 50-80% of cases are pulmonary, and the rest are either cutaneous, multi-site, CNS. But I've also listed some more rare manifestations like ocular nocardia. You can have nocardiobacteremia. How many people have had a nocardiobacteremia? Anybody yet? A couple in the room? And I think that was mentioned in another session. Visceral disease affecting the visceral organs. You can have bone or joint nocardiosis. You can have retroperitoneal disease. You can have nocardia involving the genitourinary tract as well. So any positive culture within the lungs, as I said before, requires evaluation. And nocardia in the lungs can really present in a lot of different fashions. You can have, for example, an exacerbation in somebody with COPD. They can present with a worsening of their COPD, and it can be nocardia. Somebody with sarcoidosis, for example, they have a flare-up. Is it the sarcoid or is it nocardia? Well, if you detect a positive nocardia culture in those individuals, it could be nocardiosis. And patients can present with fever, night sweats, any of the symptomatology listed here. And when you have a pulmonary case, particularly in an immunocompromised individual, those can be prone to dissemination to the brain. So you always want to suspect that in a pulmonary case. In addition, nocardia can lead to lung complications. It can enter the pleural space and produce an empyema. And particularly serious complications can include mediastinitis or pericarditis, SVC syndrome, and others. So think about those as complications of pulmonary disease. So with pulmonary nocardia, you can really see a lot of different manifestations. You can see dense consolidation. You can see a single or multiple pulmonary nodules. You can see the development of a lung cavity, for example, or you can see reticulonodular infiltrates. So just because you have a particular type of lung involvement or a particular type of lung pathology as seen on lung imaging doesn't mean that it isn't nocardia. Now, how about skin disease? Well, this can be pretty diverse as well. Primary cutaneous nocardia can present as a acute cellulitis with intense redness or erythema mimicking staph or strep disease. Or you can also have a chronic lesion that doesn't get better, like the one on the top of the top left of this slide. You can also see a lymphocutaneous disease. So lymphocutaneous, kind of sporotrichoid type of form of nocardiosis that mimics sporotrichosis or non-tuberculous mycobacterial skin disease. So the differential diagnosis there, of course, would be sporotrichosis or M. marinum, for example. And then there's also a mycetoma type form where you can have chronic foot lesions like Madura foot presenting as nocardiosis. And this can be refractory to treatment, as seen in the bottom slide, bottom photo in this slide. These are some other skin manifestations of nocardiosis. You see kind of the Madura foot on the top left, chronic skin lesion on the scalp. On the top right, a chronic kind of scaly lesion on the dorsum of the hand. And in this individual there on the bottom right, a nasal bridge lesion. Kind of resembles cutaneous leishmaniasis, doesn't it? Yeah, a little bit. This is chronic nocardiosis, obviously presenting in someone who may not have had access to medical care. So think about chronic nocardiosis as well. This could be a variety of different syndromes, but I think many of us here in the room would be surprised to hear that this is nocardia. Now, how about CNS involvement? So as we said before, CNS disease is the most common source of dissemination of nocardia, particularly from the lung. And 44% of disseminated cases, but in about 20% of cases, nocardia presents in the CNS as the primary disease. So that may surprise some of us. It certainly surprised me. And it can present as a parenchymal abscess in any brain region. So here we have an individual with a ring-enhancing lesion with a lot of associated edema. And so there's a wide differential of a lesion like this. You think about a brain abscess. You may think about CNS toxo, for example. It can be very diverse. It can be hard to know what the etiology of a lesion like this is without further investigation. Patients may present with a fever, headache, meningismus. They can have focal deficits. It can be easily confused with a CNS neoplasm, a malignant tumor. And you can have nocardia meningitis. It's mostly subacute or chronic, but when you do an LP, it tends to have morphology that's similar to bacterial meningitis. What are some miscellaneous manifestations of nocardiosis? Again, we mentioned the potential for disseminated infection, so it can affect bone or prosthetic valves. You can have prosthetic valve endocarditis due to nocardiosis. It can involve joints. It can affect the kidneys, and rarely you can have any of these syndromes that I've listed in the slide. So think about potential for ICD infections, nocardia of the testicles, keratitis, endophthalmitis due to nocardiosis. Those types of syndromes you want to think more about in immunocompromised individuals, certainly. So differential diagnosis of nocardiosis. Shout out to my colleague, Dr. House, for those of you who are fans of that series. You want to think about, for pulmonary disease, fungal infections like aspergillus, mucor, or any of the endemic fungal mycoses. Actinomycosis, I'm going to talk about that in the second half of this talk, of how actinomyces affects the lung as well. Rhodococcus equi. Both tuberculosis and non-tuberculous mycobacterial infections and lung malignancy, all in the differential of pulmonary nocardia. For cutaneous disease, just to review what we said earlier, the lymphocutaneous forms of sporotrichoid cellulitis or lymphangitis from sporotrichosis to M. marinum. But also you can see disease that resembles standard root-based strep or Staph aureus cellulitis. Also think about erysipelathrix. Also for the mycetoma type manifestation, think about actinomyces fungal infections and other molds producing that type of disease. And then cutaneous leishmania. Think about that as well. We saw a case of facial involvement that looked suspicious for that. And then also rapidly growing mycobacteria like Fortunum chelonii. And lastly, for CNS lesions, malignancy, bacterial abscess, also vascular infarction, tumor, and things like CNS toxo, and tuberculosis, and CNS fungal infection, including these organisms. So what about the diagnosis of nocardia? Well, number one, it's important to have a clinical suspicion. So if you have a patient who's immunocompromised, maybe they're on long-term steroids, and they present with pulmonary disease, or they have a CNS lesion, your clinical suspicion is very important. So isolation of the organism is really imperative for definitive diagnosis, meaning that nocardia is a disease that's diagnosed by isolating the pathogen. There aren't really a lot of other indirect methods of making a diagnosis. And this can be challenging because nocardia doesn't grow very well. It requires specialized culture growth techniques in some circumstances, and it can have a diverse presentation. But if you have tissue and you see a positive modified acid-fast stain with filamentous bacteria, that can make a presumptive diagnosis, which of course you want to verify with culture. Most routine media can support nocardia, but there are specialized selective media, namely, and for board purposes, buffered charcoal yeast extract and modified Thayer-Martin can aid in isolation, but a lot of times nocardia strains can require an extended period of time to grow, up to 21 days. Be sure and notify the laboratory that you're suspicious of nocardia so they can take the appropriate steps to isolate it. Of course, emerging methods of diagnosing nocardia and other syndromes include MALDI-TOF and metagenomics. Those are occasionally used where available. And this is very important. When you do isolate nocardia, you want to request speciation and also susceptibility testing, because that can differ by selective isolate. So based upon your isolate of nocardia, your species, susceptibility can differ, and that can be important because resistance to the sulfonamides can occur, and it can vary by species. CNS-related symptoms in anybody who has nocardia disease should always warrant neuroimaging, either CT or MRI. And if you have an immunocompromised patient, whether they have cutaneous or pulmonary disease, should always warrant neuroimaging. If you have an immunocompetent patient with cutaneous disease, the risk is much lower, but really any patient with pulmonary disease is an indication for neuroimaging, particularly if they're having CNS-related symptoms. Now, what about treatment? it's important to remember that no prospective randomized trials have ever been performed with Nocardia. So any recommendations you see about treatment are all anecdotal and based on clinical experience. So, and as I said before, there's varying susceptibility patterns among different species, and that's why it's so important to speciate out your Nocardia. If you have somebody who's immunocompetent and has skin disease, monotherapy is usually recommended. It's not necessary to double up your therapy. But you take the extreme end of that. If you have an immunocompromised patient with serious disease, you're going to want to use multiple agents, at least 2 agents, and in some cases 3 agents if you have severe infection. And the treatment of nocardiosis usually follows an induction consolidation type of strategy where you treat with very highly effective, in some cases parenteral agents, for 3 to 6 weeks until clinical improvement is documented, and then you de-escalate to usually an oral regimen for a prolonged period of time to complete your therapy. And you want to base your weaning of coverage upon susceptibility testing and the clinical response. And a lot of consolidation treatment can be oral, of course. So as I said before, Bactrim is a mainstay of therapy, but there's growing resistance. Interestingly, the trimethoprim in Bactrim really doesn't do anything. I mean, the sulfonamides that have susceptibility, it's just that Bactrim is the most common sulfonamide that we have available. Among the aminoglycosides, amikacin is usually the drug of choice that has the greatest susceptibility, and the other aminoglycosides like toberin and gentamicin are less reliable. The susceptibility among the carbapenems varies as well, but imipenem tends to be the best. Third generation cephalosporins, much less reliable. And linezolid is actually effective, but the question is, this is a disease that you treat for weeks and weeks, and how do you integrate a oxazolidinone into that when, with linezolid, for example, there's really duration-limited toxicity amongst those agents. And these other antibiotics have activity against Nocardia, Augmentin, believe it or not, fluoroquinolones, tigecycline, and dapsone all have activity against Nocardia. So this is from up to date, and this is the best representation of these complex regimens of nocardiosis that I could find. And so again, for isolated cutaneous infection, Bactrim or minocycline, Bactrim or minocycline are effective. If you have somebody with a mycetoma that's not severe, consider Bactrim or dapsone. Mild or moderate pulmonary disease, you can still get away with single agent therapy. And mild or moderate pulmonary disease in immunocompromised hosts, you want to escalate your dosing, but still single agent therapy is okay. Now, if you have severe disease, this is where you get into the multiple agent regimens, at least for induction, the induction portion of therapy. And to scroll down to life-threatening disease here, you see where you're talking about high-dose Bactrim plus imipenem plus amikacin, at least for the induction phase of therapy. So again, the duration of therapy, that's all expert opinion. There's no randomized clinical trials. But you know what? In a lot of infectious disease, that's the case. I mean, really, our regimens for a lot of other syndromes like prosthetic joint infection, and they can never do a randomized trial for duration. So a lot of times it's expert opinion. But experts agree that for skin disease, you can treat for as little as 3 to 6 months in simple cases, up to 6 to 12 months in complicated disease. Lung disease, 6 to 12 months in immunocompetent, but if you have an immunocompromised patient or if you have CNS disease, you may be treating for longer than a year. And severely immunocompromised patients may require secondary prophylaxis, oftentimes with Bactrim, right, to prevent recurrence. Somebody with solid organ or a bone marrow transplant, patients on extended doses of glucocorticoids, those who are on extended chemotherapy regimens may require secondary prophylaxis to prevent recurrence. So this can be a very persistent infection that can recur. in the most vulnerable or susceptible of patients. If you have somebody who's immunocompromised and you can reduce their immunosuppression, that may help. And you always want to monitor for drug toxicity, particularly, Bactrim can cause all kinds of toxicity in extended use, bone marrow suppression, increased creatinine, drug sensitivities, and so forth. Follow-up imaging is not a bad idea. And some cases, surgical intervention or procedural intervention can be helpful. If you have somebody with pericarditis or empyema, for example, sometimes you need debulking, and that's where surgical assistance can help. So I'm going to take questions, but how many of you know what this is? If you're under 45, you probably haven't used it. How many people have used a manual transmission? Oh, a couple of you. Okay. Well, I don't mean to be ageist here, but I put this up just to say that we're going to be shifting gears after I take any questions. So any questions about the Nocardia portion of our discussion?
Are there any, I'm sure there's probably case studies, but like transmission, like skin inoculation from bug bites or mosquito bites? Or
I haven't heard that characterized, but I wouldn't necessarily rule it out. I think most skin and soft tissue exposure has to contact a contaminated surface, and so that would tend to be more animal bites rather than envenomations. But that, I'm going to look that up after the talk, and if I find anything, I'll get back with you. So good question, though. Any other questions about Nocardia? If not, we'll go on to talk about Actinomyces. So Actinomyces, as I said, shares a lot of similarities because it's in. Yeah, was there a question online or comment? Nope. Last chance. All right. So as I said, Actinomyces shares a lot of similarities and differences. It is also, as I said earlier, a branching gram-positive bacillus. And it was described by Israel in 1878, and that's the reason why the most common species causing human disease is called what? Actinomyces israelii, right? So unlike Nocardia, Actinomyces is part of the normal flora. It is a commensal, and it prefers places like gingival spaces, tonsillar crypts, carious teeth, for example. So if you have cavities, you can harbor Actinomyces within that carious tissue. It also tends to inhabit the GI and urogenital tract. So a big distinction to Nocardia, where the presence of any positive culture implies the possibility of human disease. Actinomyces can be in a culture from a expected location and not be considered pathogenic. So
Israel is the country Israel or person?
No, I think it was a person.
Okay.
Israel. Someone who described it in 1878. So, like Nocardia, Actinomyces is in the class Actinomycetia, but it is different in that it's the order Actinomycetalis and the genus Actinomyces. So these are related genera. So both Actinomyces and Nocardia share classification with Mycobacterium and Cutibacterium, for example, among others. There are more than 30 species. And as I said earlier, Actinomyces israelii is the most prevalent human disease. And certain species have more of a predilection for certain types of syndromes. So odontolyticus, for example, tends to occur as a bacteremia. And as I said here, and Actinomyces odontolyticus has been reclassified to Shalia. So you may also see Shalia odontolyticus. Actinomyces has a worldwide distribution, similar to Nocardia. But unlike Nocardia, humans are the only reservoir. So Nocardiosis occurs in animals, but Actinomyces just occurs in humans. Infections are generally uncommon. I think here we have a handful of cases each year. But some of that may be, it also is difficult to diagnose. You have to suspect it clinically, right? You may not consider nocardia initially with some of the manifestations of this disease. So you have to go out and look for it. And it's not strictly an opportunistic pathogen. It's mostly a disease of the immunocompetent. So another distinction with nocardia. So actinomyces can be difficult to culture, mainly because it's an anaerobe. And so if you're not undergoing specialized handling, transport, and growth requirements, you won't grow out actinomyces. It also grows quite slowly. It takes up to 15 to 20 days to grow. But it does have preferential media, and it can culture on chocolate blood agar at 37 degrees C and other selected media as well. And on gram stain, as we said before, it's a gram-positive filamentous rod. But the difference is, of course, it is an anaerobe, right? So these are typical culture morphologies that you may see. The molar tooth colony, it sort of looks like a molar, right? That's characteristic for Actinomyces israelii. And you may see red or rust brown colonies with Actinomyces or Shalia odontolyticus, for example. So be aware there's some morphological differences on culture that distinguish some of the species. And the molar tooth colony, that could easily be a board question. So another characteristic of Actinomyces is that it forms sulfur granules, characteristic sulfur granules, but only in tissue, only in vivo, not in vitro. So you don't see sulfur granules when you grow it out on culture, when you plate it out, but you do see it in tissue. And this can be a very characteristic type of finding. MALDI-TOF identification is emerging as an important diagnostic tool, as it is for nocardia. So we may be able to speciate some of these that were more difficult to do so before. So it's important to remember that for actinomyces, there are three main areas of involvement. So when you see this in causing human disease, it may cause one of three different syndromes for the most part. About half of those cases involve cervicofacial disease. So a common characteristic is so-called lumpy jaw. In about 20% of cases, you can see abdominal pelvic disease involving either the bowel or the peritoneum or, for example, the urogenital organs. And about 15 to 20% of cases involve thoracic disease, pneumonias, empyemas, and so forth. And actinomyces is very distinct from nocardia and other infections, for example, in that it tends to ignore tissue planes, though it prefers localized spread. So if you have, for example, cervical facial disease, you may have somebody with traumatic situation with the jaw, the mandible, for example, or with teeth. And that infection that sets up initially can cross tissue planes and actually result in a draining lesion of the jaw, the external jaw, that you wouldn't normally see with other cases. If you have an anaerobic infection of a dental carie, for example, that's not going to cross tissue planes and actually transect the face and drain externally. But this is a characteristic of actinomyces that's important to be aware of. And that can occur in other body regions as well. So speaking about oral cervical facial disease, this is the most common form, and patients can be predisposed to developing cervical facial actinomyces by some of their habits. What kinds of habits? Poor oral hygiene, for example, smoking, alcohol use, poor dentition, having frequent dental caries, or having metabolic syndromes like type 2 diabetes, being malnourished, or somebody with head and neck cancer who has osteonecrosis of the jaws. You can also be at risk for actinomycosis if you have dental implants. Some people have dental implants, they have bone grafting of the jaw, that can lead to actinomyces. Mucosal trauma as well, somebody who, for example, has trauma to the jaw through an auto accident, for example, or a traumatic extraction of dental tissue. can present with actinomyces. And the typical presentation is of a slowly progressing type of infection, kind of a smoldering infection over weeks to months, usually non-painful. And typically, typical presentation is erosion to an external lesion. Now, most people who are not familiar with actinomyces may look at something like this in the photo and say, this patient has a cyst of their face, and administer them a short course of antibiotics against skin and soft tissue pathogens. And paradoxically, the lesion may get better for a short period of time because they had a short course of antibiotics, but then it may worsen again, and that can hamper identification and diagnosis of the lesion. I had a case just like this in one of our clinics, for example, and the difficulty about it is the lesion had been cultured multiple times and had grown out nothing. So in the end, we decided to treat more for the syndrome than because we had culture-based confirmation. And within a few weeks, the lesion had completely resolved, and we concluded that this patient who had some of these risk factors had cervical-facial actino. So just because you don't have a positive culture doesn't mean that you don't have the syndrome. And in some chronic cases, it can look like cancer, and patients may have biopsies done looking for malignancy, and in fact, it's cervical-facial actinomyces. And so be aware of that. So that's the most well-recognized type of actinomyces. Lesser recognized is really abdominal pelvic disease, even though it does tend to occur with a fairly reasonable frequency. And this typically occurs in people who have abdominal infections or have invasive procedures. So you may have somebody who has a periappendiceal abscess, for example, or who has a laparoscopic cholecystectomy, never gets better. Maybe they have erosion to a chronic draining lesion. Somebody who has prolonged use of an IUD. IUD infections associated with nocardiosis have been described. Somebody with a hysterectomy who develops an abscess. Those are all cited cases of actinomyces in abdominal pelvic manifestations. Sometimes it can be confused with Crohn's disease, producing chronic lesions, abdominal malignancy. It can be confused with tuberculosis, with extrapulmonary tuberculosis. And many cases are diagnosed when, let's say, somebody's suspected of having a malignancy and they get a laparoscopic procedure or an exploratory surgery, and it's diagnosed after surgery. CT-guided percutaneous aspiration can also be very helpful. Now, what about thoracic disease? Believe it or not, we do see thoracic disease with some frequency. And although you can have hematogenous dissemination to the lungs, in many cases, these cases occur because of aspiration of oropharyngeal secretions into the lung, and that sets up a chronic infection that can be easily confused with other chronic causes of persistent pulmonary infiltrates like TB or a lung tumor. And it can also be confused with routine pneumonia because of its manifestations. It can present with a chronic consolidated pneumonia in a patient with chronic lung disease, for example, or somebody who's prone to aspiration. And its slowly progressive nature can be very confounding. And in a case series, 1/3 of these were initially diagnosed as lung cancer and not actinomycosis. So some of you are familiar with this case. We may have talked about it at a previous conference, as a matter of fact. So this is a patient presented to our facility, 76-year-old fellow. He had coronary artery disease, pulmonary hypertension. He was a smoker, and he had dysphagia. And he presented with chronic cough, shortness of breath, with yellow foul sputum production. This was his CT just last month. Demonstrated large right lower lobe consolidation with scattered micronodules. So he had a bronch, and it was positive exclusively, which is unusual because a lot of times you may culture out multiple pathogens with actinomyces. So it was positive for 9 colony-forming units of Shalia odontolytica. So patient was diagnosed with actinomyces or Shalia odontolytica pneumonia, more likely to have occurred through aspiration, but can't rule out hematogenous spread. The patient was recently seen in our clinic after completing 3 weeks of aqueous penicillin G, 18 millunits a day, and should have been transitioned to PO penicillin VK for an anticipated duration of 1 gram TID for 3 to 6 months. It's going to be re-imaged in March to see if this is resolved. So think about thoracic actinomyces as a cause of chronic pneumonia not getting better, or maybe you're suspecting lung cancer and it's really actinomycosis. Now, some other manifestations of actinomyces can occur. Again, we talked about cutaneous disease, but it's not always cutaneous disease of the jaw area. Think about chronic draining abscesses or fistulous tracts in other areas, such as the abdomen. You can have extension from a intra-abdominal focus, for example, or a pulmonary focus to the spine. CNS disease can also occur, usually as extension of local lesions of the head and neck area. And it can present as single or multiple brain abscesses, for example. So nocardia is not the only one of these types of syndromes that can involve the CNS. You can have disseminated disease, and ophthalmic infections have been described, urinary tract infection, bacteremia, sepsis, and also you can have actinomyces endocarditis as well. So be aware of some of the multiple manifestations. And this slide demonstrates that different strains of actinomyces can have a predilection for different areas of the body. So for definitive diagnosis, you really need culture of actinomyces from the pus or bone. Remember, definitive diagnosis. But if you identify some of the actinomycotic sulfur granules within tissue, that can be a strong indication that you're dealing with actinomyces. Remember that your modified acid fast stain isn't really helpful, right? Because these are modified acid fast stain negative. Only Nocardia is modified acid fast stain positive. And Gram stain, of course, can't distinguish between these. And I mentioned that repeatedly because if there's one thing you remember about this, I hope you remember that because I mentioned it multiple times. So what about treatment? Well, penicillin therapy is considered the gold standard. And in serious infections, parenteral therapy is preferred, usually with aqueous penicillin G, 10 to 20 million units per day, as we did with our recent patient. But ceftriaxone is an alternative if you have a penicillin allergic patient. And then for oral therapy, hopefully you can use a beta-lactam drug like penicillin VK or amoxicillin for less serious infections for step down, treat the patient for a prolonged course. But in a penicillin allergic patient, doxycycline, the macrolides and carbapenems also have activity. Treatment also follows an induction consolidation strategy. So induction is usually for 4 to 6 weeks. Step down to oral therapy occurs after that. If you have mild disease, usually 2 to 6 months. If you have particularly severe disease, let's say you have osteomyelitis because of extension of a pulmonary or abdominal primary infection, you may be treating for a lot longer, 6 to 12 months, for example. But treatment length is really individualized based on the burden of disease, where the infection is located, whether there's been any debulking that has occurred via surgery. And that's more important in complicated infections. Let's say you have somebody with an abdominal pelvic infection due to actinomyces. You really may need to debulk that infection in order to get optimum treatment. And as I said before, oftentimes you can see polymicrobial growth, actinomyces plus, let's say, Corynebacterium or coag-negative staph. Do you really need to treat those other organisms? Probably, of course not. You really need to consider whether those other organisms are likely to cause disease. So if I see actinomyces and Staph aureus, for example, of course I'd want to treat that. But if I see actinomyces and bacillus, ignore the bacillus. All right, so we're near the conclusion of our talk, and we're going to talk about, again, we're going to briefly review and compare and contrast actinomyces versus Nocardia. So each of you will no longer be confused about how these are different if you were before. I'm sure many of you already are aware of many of these things. So again, Actinomyces prefers certain body sites, and it is a commensal, right? The normal flora of the oral cavity, the mouth, colon, the vagina. Nocardiosis, non-commensal. The presence of it in any human culture is considered abnormal, and it is a non-commensal, and it prefers the soil. Actinomyces is primarily a disease of immunocompetent hosts, whereas Nocardia predominates among the immunocompromised in 2/3 or more of cases, particularly in those who are on long-term or high-dose steroids, but also these other manifestations as well. Less likely HIV in the modern era, more primary immunodeficiencies or those with transplants. Primary site for Actinomyces, the mouth, the lung, appendix, uterus. Nocardia tends to prefer affecting the lung and skin and soft tissue. Nocardiosis predominantly spreads to the brain, but can spread to other areas. Actinomyces prefers contiguous spread because it crosses tissue planes. And actinomycosis can have a very chronic and prolonged course, whereas Nocardia tends to present not acutely, but more subacute. The primary drug of choice for actinomyces are beta-lactams like penicillin and amoxicillin. Ceftriaxone also is an option, plus these other agents. Nocardia tends to have as its primary therapy Bactrim, predominantly because of the sulfonamide, not so much the trimethoprim. Sulfasoxazole also effective, but these other agents can be considered in the treatment of Nocardia. Third-generation cephalosporins are really at the bottom here. So here's my summary, and I see we're finishing more or less on time. Nocardia and Actinomyces are related organisms within the Actinomycetia class. Although both organisms can cause disease in normal hosts, Nocardia infections more commonly among the immunocompromised, right? Whereas Nocardia is primarily a pulmonary and soft tissue infection that can spread to the CNS. Actinomyces primarily causes cervical, facial, and abdominal pelvic infections, but can also cause thoracic disease, as we saw in our recent case. Both Nocardia and Actinomyces are diagnosed through clinical specimens and have difficult culture requirements. Both Nocardia and Actinomyces require prolonged treatment with distinct antimicrobial regimens. And lastly, you have to suspect these syndromes in order to be able to diagnose them. So I hope that this lecture has given you a refresher on when to suspect them, when to consider them, and in some cases, when to consider empiric treatment when you don't have a positive culture. So with that, that's my talk. And are there any questions? All right. Thank you all very much.